Very good evening, ladies and gentlemen. I'm Dr. Rohita Shetty, and on behalf of the General Medicine Division of Abbott and the AOI Mumbai branch, I extend a warm welcome to each one of you present here today. A special thanks to the AOI Mumbai branch because they have been instrumental in making this event happen today. Moving on, the event is called Spectrum International Speaker Program. This is a 3-city tour wherein we started the program in Chennai yesterday, Mumbai today, and would be concluding in tomorrow. For the program, we have an international expert, Professor Valerie, who's come from UK, and all of you can be rest assured that the insights you all are going to be gaining post the talk of our international experts today are going to be very valuable. On that note, I would now request Dr. Kaushal Seth to kindly grace the dais. Dr. Kaushal Seth is the AOI National Secretary, AOI Mumbai President, a consultant ENT and head and neck surgeon since the past 18 years. He's a consultant robotic and sleep apnea surgeon. He's got a lot of achievements to his credit, just to name a few. To start with, he's aced his academic career. He's been a gold medalist in the DORL examination, had the Best Dissertation Award too. Sir has a lot of affiliations, to name a few of them. Sir is a part of the Seth AJP Municipal ENT Hospital, Fort Mumbai, a part of the Excel ENT Hospital, Mumbai, a part of the Asian Heart Institute, Mumbai, and so on. Sir, I would request you to kindly accept a floral bouquet on our behalf as a token of our gratitude. I would like to call upon Dr. Nishant to kindly come on stage and hand over a floral bouquet to Dr. Kaushal Seth. Dr. Nishant is the Head Marketing General Medicine, Abbott. Ladies and gentlemen, a big round of applause. Thank you, sir. Thank you very much. Next, I would request the dynamic honorary secretary of the AOI Mumbai branch, Dr. Ajay Devfede, to kindly grace the dais. Thank you, sir. Sir has also been a student during the academic life. He's been a student par excellence, is ranked and come on the merit list even in his postgraduate examinations. He's a master of art. He's mastered the art of surgeries like FES, endonasal, endoscopic, ophthalmic surgeries. He's having a number of publications to his credit, a number of presentations and deliberations in the national and international conferences. He's even conducted workshops for the young clinicians to gain expertise in their clinical practice. He's currently affiliated with the Nanavati Super Speciality Hospital, the Prime ENT Clinic, Andheri. He's the head of unit, HBT Municipal Hospital, Jogeshwari, and so on. But without any further ado, I would now request Mr. Gyan, the National Sales Manager of the General Medicine Department, Abbott, to kindly hand over a floral bouquet to Dr. Ajay as a token of our love and gratitude. Ladies and gentlemen, I would request you to again give a big round of applause for both the moderators for our event today. Dr. Kaushal, I would request you to kindly address the gathering.
Hello, good evening, friends. On behalf of AOI Mumbai, I welcome you all to this wonderful academic evening. At the outset, I would like to say that as ENT surgeons, we always look at the surgical aspect of the treatment of the disease. But to say the least, medical management is also very important. And this time, probably the first time in the recent past that we've held a CME on the medical management of a disease. I really like to thank Abbott for coming forth and supporting us for this. Next, I would like to say that we are really grateful and obliged for Professor Valerie to come here to Mumbai, and I'm sure we'll have a wonderful academic evening today. Without taking much time, let me call Ajay to take over the proceedings. Thank you.
Yeah. Okay. Thanks, Kaushal. Good evening once again, everybody. As a good surgeon knows when not to operate, so should a clinician know what infections and with armamentarium in his arsenal he should use. So today's CME is focused on ENT infections, and without wasting much time, I would like to introduce our esteemed speakers. It's an honor and privilege to call upon Professor Valerie on the stage, and I request our President, AOI Mumbai, Dr. Kaushal, to welcome her with a floral bouquet. Professor Valerie is Professor Emeritus at Royal National Throat, Nose and Ear Institute. Madam, can you please come on stage, Kaushal? She is a consultant at Moorfields Eye Hospital. Ma'am, you can take a stage. You can sit. I'll call you later on. She's also at the University College Hospital. She has an excellent academic career. She has won several laurels, including prizes such as George Davy Howell, W.J. Harrison, Sir Arthur Sims Commonwealth Professorship, so on and so forth. She has contributed immensely to literature. She has about 36 books and monographs, 86 chapters, and over 320 peer-reviewed papers. She has lectured throughout the globe widely, delivering 18 eponymous lectures, including the Simon Sturck Adams and Stell lectures in the last 3 years. And she is the only non-American editor of Cummins Otolaryngology, and her most recent book, Tumors of the Nose, Paranasal Sinuses, and Nasopharynx, was published by Time in the year 2014. Welcome, ma'am. Welcome to Mumbai. I believe this is your first maiden visit to India. Our next star faculty for the evening is Dr. Nishit Shah. I request Dr. Nishit Shah to come on stage, and Dr. Hetal, our immediate past president, AOI Mumbai. Please welcome Dr. Nishit on behalf of AOI Mumbai and Abbott for this evening. Dr. Nishit Shah is a consultant ENT specialist at Bridge Candy Hospital. He is also attached to the Bombay Hospital. Nishit is the pioneer of endoscopic skull-based surgery in India and has the highest number of endoscopic pituitary surgeries in India. He is a postgraduate teacher in Bombay Hospital. He has multiple books and publications to his credit, and we are looking forward to hear him in the next coming few minutes. And finally, last but not the least, our very own Dr. Sameer Bhargav. I request Dr. Sameer Bhargav to come on stage, and Dr. Ritu Seth, on behalf of AOI Mumbai, will welcome Dr. Sameer. Dr. Sameer is currently professor at HBT Medical College and consultant at Hinduja Hospital. He has a meritorious academic record. He has various publications, and he's co-authored a short book, textbook of ENT diseases, which has been read by most of us, and the current count is about 2.5 lakhs. Welcome, sir. So, setting the ball roll started, I request Professor Valerie to come on stage and deliver her talk. Okay, sorry. So we have a little change in the order. So I request Dr. Sameer to come and deliver his lecture first.
Good evening, friends. At the outset, I would like to mention that it's indeed an honor and privilege to be sharing the dais with Professor Valerie. And I would like to thank Abbott India for having given us this opportunity to be able to interact and listen to Professor Valerie. In fact, when they approached me saying that we were having an international speaker here for this program, and when I asked them, who is it? And they said, Professor Valerie Lund from UK. I said, oh, she hasn't been here earlier, and we would all very much like to have her here. And thank you once again for making that happen. Now, normally at an ENT meet, we have talks on surgical aspects of how to manage ENT conditions. And today we are going to talk about the medical aspect, and before Professor Valerie can tell us what's new and how we can manage them better, I'm going to briefly talk about the recurrent ENT infections and the Indian perspective. Now, in our day-to-day practice, we come across several patients with recurrent infections in the head and neck and ENT. And besides the disease factor, there are patient factors, there are environmental and socioeconomic factors which are responsible for these infections happening recurrently. Besides that, we have a large number of rare, or I would say is not so common infections which are unique to the Indian subcontinent, be it tuberculosis, be it fungal infections. But today's topic is on recurrent infections and the common ones at that. So let us see why we have these infections more commonly in our country, and one of the reasons being the tropical environment and pollution to add to it, which is present almost all through the country. We have a population of 125 crores and very densely populated country. Besides, a large number of our population is the rural population, which has limited access to healthcare. Added to that, poverty, illiteracy, malnutrition, poor hygiene, lack of awareness, and all these result in the late presentation of the patient to the health provider. In fact, a lot of times the problems are neglected, and then the recurrent infections keep happening. And add to that is the distance that quite a number of patients from the rural areas need to cover to even get the basic healthcare, leave alone visiting a consultant. And what's even peculiar about our country is the treatment gets affected by cultural prejudices. We have immunocompromised status of patients, particularly diabetes mellitus, and I'm not too happy to say that India is the capital or the world capital of diabetes. We have more than 60 million patients in this country. We have a lot of alternative forms of therapy, not all of which are not so good, but added to that, a lot of quackery, which is also responsible for infections not really coming under control and hence becoming recurrent. And what we have now is antibiotic resistance and biofilm. So I will dwell upon that in a little more in detail a little later on. So let us see what exactly is the burden of this commonly occurring ENT infections. As I said, given the magnitude of our population, even a small percentage can translate into huge numbers. So we all know that an acute rhinosinusitis most often is viral, could be bacterial, but almost 0.5% of URTIs can be complicated by sinusitis. and of which it's more common in children, so almost 5 to 13% of URTIs in children can complicate into an acute rhinosinusitis. CRS, which is chronic rhinosinusitis, is an important public health problem, and it can affect almost more than 5% of the population of a country. And at any given time, a survey which was done in North India showed almost 1 to 1.5% of rural population getting affected by that. Now we have various classifications, but broadly it is now chronic rhinosinusitis with nasal polyposis or without. And nasal polyps form a very large number of a problem, particularly among our adult population, ranging anything from 1 to 4%. The other problem, of course, as we all know, is the incidence of high recurrence rate with whatever form of treatment we do for nasal polyposis, and we'll have Professor Valerie giving us some insight as to how to reduce that in the latter part of the talk. We have a large number of allergic fungal rhinosinusitis patients, and a study done both from the north as well as South India showed that the incidence can be anything ranging from a 21% to a 46%. And typically, the environmental air analysis for fungus has revealed that there is an abundance of Aspergillus spores. This tends to be more during the winter season, and they've noticed a spike in the Aspergillus flavus conadial burden during winter, particularly when the wheat harvesting season comes up. And that's what explains why we have a very high incidence of fungal disease. Fungal disease, as we all know, can be both invasive and non-invasive, and of course, the invasive variety being generally in the immunocompromised state. But since we mentioned that we have a large number of patients with an immunocompromised state, we see a large number of mucor cases nowadays. Coming to otitis media, and according to various surveys, the World Health Organization has reported that a hearing impairment in 42 million people above the age of 3 years was mainly caused by otitis media. And in our country, in a survey, we had almost 9.2% of patients, preschool children, who have suffered from otitis media, of which the prevalence of acute otitis media is around 17 to 20%. And most of these patients are prescribed antibiotics, whereas a meta-analysis has demonstrated that approximately 80% of children would have a spontaneous relief of the AOMN within 2 to 14 days. So we need to do rethink on how many antibiotics we need to prescribe for our patients. Coming to chronic otitis media, the prevalence in India is about 7.8%, and we all know that a large number of these patients will need surgical treatment. Now, surgeries, particularly in the metros or the tier 1 cities, we can expect a good outcome in majority of patients because of good surgical techniques, for good equipment. But a large number of our patients have to travel long distances, and hence chronic otitis media treatment for that can be quite a problem. Otitis media with effusion in a study done in South India showed 16.6%, which is a large number. And now chronic biofilm colonization of the adenoids may be acting as a reservoir for bacteria entering the middle ear cleft. So that could explain why the incidence of effusion is going up, along with the incidence of adenoids. So, knowing the magnitude of the problem, let us see what are the challenges that one faces in the management of these common ENT infections. I've divided into the patient perspective, the physician perspective, biofilms, and antibiotic resistance. Now, from a patient point of view, most of the ENT infections are not life-threatening, but they affect the quality of life in a large way. And whether it be a rhinosinusitis causing airway obstruction, causing a postnasal drip, causing a poor olfactory function, or an otitis media, which results in a social restriction for the patient because of the hearing loss, most of the problems from the patient point of view, they hamper their quality of life. Of course, when the problems go on for a long period of time, then the cost of therapy also comes into play. But from a surgeon's point of view, from a physician's point of view, we need to decide judiciously as to which patients will require surgery. And that, as Dr. Ajay mentioned, that it's very important to know when to operate and when not to operate, and that would depend upon the physician's expertise. Coming to biofilms, a subject which a lot has been written now, and maybe a few years ago we weren't even aware of it, but the presence of biofilms is there in almost 65% of chronic infections in humans. And what are biofilms? So they are microorganisms, basically bacteria, embedded in a protective extracellular matrix consisting of an extracellular polymeric substance such as proteins, nucleic acids, enzymes, polysaccharides. And these can be the cause of a lot of our problems in the patients. Now, almost 99%, that is like each and every bacteria, would be having the ability to form this biofilm. And no wonder the incidence of resistant infections is going up. So what the biofilm does is that it leads to a resistance to the phagocytosis and a reduction in the efficacy of the antimicrobials that we are using. There are various mechanisms by which this can happen, and I'm not going to go into the details of that. But suffice to say that because of biofilm formation, we need markedly higher antibiotic doses to control the presence of this, compared to the doses that you would be using with your in eradicating the regular planktonic bacteria. There are various measures that have been suggested, which include mupirocin irrigation, use of gentian violet, thiamphenicol glycinate, various things. And also of late we have come to know about manuka honey, which is another means of trying to eradicate this biofilm formation. Besides that, a physical disruption, maybe in the form of surgery, surfactants, probiotics, and in surfactants, the simple 1% baby shampoo, that can also play a role in getting rid of these biofilms. Besides, macrolides have also been shown to alter the structure and the function of biofilm produced by the Pseudomonas aeruginosa. And it has been observed that macrolides may be able to reduce the tissue damage caused by certain bacteria without directly causing an antibacterial effect. So an immunomodulatory or an anti-inflammatory property. The other challenge that we face as clinicians is the emerging antibiotic resistance. And when there is excessive use of antibiotic, that's where you can land up with antibiotic resistance. So in India, 2010, a study was done, and that showed that India was the world's largest consumer of antibiotics for human health. The poor public health infrastructure, the high incidence of disease, cheap, unregulated sales of antibiotics, all these have created the ideal conditions for a rapid rise of the resistant infections. And in India, we have this unique feature of across-the-counter non-prescription sale of carbapenems, and this has resulted in a fairly high incidence of carbapenem resistance. Also, the newer resistance mechanisms that have come up with the various infections has resulted in antibiotic resistance becoming a major problem. So what exactly, what is the mechanism? And exposure of a sub-MIC concentration of antibiotics, it will increase the mutation rate, and this will lead to an antibiotic resistance and generate a more resistant phenotype. So this is what happens when we use antibiotics not so judiciously in smaller concentrations. And a lot of times we have patients who have taken a shorter dose or a reduced dose, not according to their body weight or according to the severity of the infection. And a challenge probably in the years to come is not how to treat an acute otitis media, but how to prevent this acute otitis media. This rather busy slide just highlights the incidence of resistance that is developing, and I will just pick upon one or two instances. Children in an outpatient department for acute pharyngotonsillitis, a group A beta hemolytic streptococcus, 10 to 25% resistance to macrolides, tetracyclines, and also to chloramphenicol. We have another incidence where you have in a tertiary care hospital, again resistance to Pseudomonas, and you had carbapenemase, which is resistance, and this would lead to a huge amount of problems. So before I conclude my talk, I want to dwell a little bit on the hospital-acquired infections, because a lot of times when you have these problems coming up, you have patients who are not only getting a hospital-acquired infection, but an antimicrobial resistance in the ICUs. And more number of patients will land up into ICUs with all the problems that we see nowadays. This results not only in the increased length of the stay of the patient, the financial burden, increased mortality rate, but reduction in both hospital-acquired infections and the antimicrobial resistance is a very challenging problem for health administrators all over the world. The increasing trend of multi-drug resistance, especially to the higher generation cephalosporins and carbapenems, is something that we need to be really worried about, because if we are finally left with no antibiotic other than colistin, and in the years to come we don't see any newer antibiotics, we all understand that we could be in deep trouble. So on a somber note, I would like to conclude that antibiotic resistance and biofilm formation are one of the major problems that the otolaryngologist in India is facing. As I mentioned earlier, the across-the-counter sales of these high-end antibiotics has resulted in antibiotic misuse, abuse, and resistance. And what we actually require is a well-regulated antibiotic policy with very strict antibiotic regimen, not only at the tertiary level of the institutions, but also at the primary and the secondary level. And this probably is really the need of the hour. Thank you.
Thank you, sir. That was an eye-opener. Now, before I call Professor Valerie, for whom all we have come and all waiting eagerly, Dr. Chris has just brought to our notice, I've not mentioned that in our introduction, that the Professor of Rhinology post was created in a Year Institute, specially for Madam, in the University College of London. Madam, we are eagerly waiting to hear from you.
Well, thank you very much indeed for those very kind words. As has already been noticed, that I have only the first time come to India on this visit, although I have received many kind and generous invitations from colleagues in the past. It unfortunately has not worked out, so I was more than happy to accept Abbott's invitation to come and talk to you, as this seemed the perfect opportunity. And I see it really as a reconnaissance trip, because I'm sure that having been here and been looked after and seen so many friends and colleagues, that I will be here again. So thank you very much indeed. But they did give me quite a difficult task, and that was to talk to you in 40 minutes about clinical pearls in the management of recurrent ENT infections with a focus on clarithromycin. Pearls are something that I have a particular affection for, but they then said, well, could you possibly cover all of this? and I'll do my best. So we're going to talk a little bit about acute and chronic rhinosinusitis, post-operative treatments to try and improve surgical outcomes, and then say a few words about clarithromycin in other acute upper respiratory tract infections with which you're all familiar. So if we kick off with acute rhinosinusitis, some of you, I hope, will be familiar with the EPOS document, which I have been a co-chair of since 2005. And in that, we've tried to define the condition that covers both acute and chronic rhinosinusitis as an inflammation of the nose and sinuses. Now, obviously, the nose and sinuses have a limited way in which they can manifest symptomatically that infection or inflammation, i.e. blockage, congestion or obstruction, some form of discharge from the front or the back of the nose. And in adults, that will also include problems with the sense of smell, but particularly in an acute situation, significant facial pain or pressure. In children, it's slightly different because clearly it's more difficult for them to tell you about their loss of smell, but they will often get a cough. And in either case, we have pragmatically defined the condition by a 12-week break point. So if you have a condition which is longer than 12 weeks, then it is a chronic condition. But if it's less than that, it's acute. Of course, we know that acute bacterial rhinosinusitis lasts a much shorter period than that for most people. But it's the point about complete resolution of symptoms which defines the acute episode. Now, these are conditions, as we've already heard, are extremely common. Everybody in this audience has suffered from a viral cold at some point, and children obviously get even more than adults. A small number, relatively, go on to develop a bacterial infection. But when you consider the number of viral infections that are occurring in the nose and sinuses, this actually translates into a huge number of cases. And that, in turn, has a big societal cost in terms of time off work, visits to GPs, and obviously the cost of actually treating these conditions. So if we can sort of put it diagrammatically, here we have the globality of acute rhinosinusitis, of which bacterial disease is actually a relatively small amount. And one of the problems we have, and we've just heard that very elegantly explained, is actually making sure that when we use antibiotics, these are precious drugs that we need to use appropriately and to make sure that we deal with the problem when it's required and not to give them when it's not required. So if we use this diagram, we can see that the vast majority of people are getting better from their common cold, but we do have a group who, for whatever reason, go on with persistent symptoms, which continue for at least 10 days, or indeed may actually start to increase after 5 days. And this is what we've called a sort of post-viral problem. It hasn't become a full-blown bacterial disease at that point, but it may go on to become a full bacterial disease when, of course, the discharge is very discolored, the patient has very severe localized pain, and indeed may have a fever and positive markers of infection and inflammation. But it's quite difficult sometimes when patients come and see you, they may actually be coming in this period. And that's when they are asking you to give antibiotics, and you really don't want to give them because you want to give the antibiotics when there is genuinely a bacterial infection. And what is that bacterial infection? Well, I like to call them the usual suspects. They're basically a combination of bacteria, Strep pneumoniae, Haemophilus influenza. We recognize that Staph aureus is now a major player in these conditions, and other things such as Moraxella, and of course, not forgetting the anaerobes. Now, if you look in the documents, I don't know that this projects very well, particularly with the lights, but we can see here that there is good level 1 evidence, grade A recommendations for quite a lot of medications in adults with acute rhinosinusitis. And of course, antibiotics are the most commonly used. But I'd just like to point out to you that topical steroids either alone or in combination with an antibiotic, but particularly alone, can be very useful in treating that post-viral period before the patient actually has a bacterial disease. There have been a number of studies now showing that they will reduce symptoms and speed up recovery, particularly relating to mucociliary clearance. So many of these drugs are simply masking or reducing symptoms. It's difficult to genuinely cure infection, which is what we hope the antibiotic will do. In children, there are fewer studies, but again, antibiotics and topical steroids are available with level 1 grade A recommendations. In the children, it's mainly been studies children of 12 years or above, but they have again been shown to help in this post-viral period. Now, Cochrane has looked at these aspects on a number of occasions. The last iteration was in 2012. It's interesting, you see there are over 1,300 studies looking at antibiotics in this situation, but only 10 that actually fulfilled the criteria of a true randomized controlled trial with a placebo arm. And that nonetheless include just under 2,500 patients. So we know that if patients are not treated, even if they have a bacterial infection, quite a lot of them will get better. But if we do give an antibiotic, we can anticipate that in an appropriate situation, they will shorten the time to cure. It's a modest improvement, but it may be significant when you think about the amount of work that's lost and with other societal costs that go with infection. So in most of the guidelines that you see, certainly in the UK and elsewhere, we do not suggest that people use antibiotics in adults, certainly during the viral or post-viral period, and also not in the milder or moderate uncomplicated acute rhinosinusitis. Now again, I doubt that this is going to project at all well in this light, but this is one of the algorithms from EPOS, and here you see that the recommendation is for antibiotics to be reserved for the more severe pathway in patients who fulfill the criteria of an acute infection. And also bearing in mind, of course, that we must be aware of the potential for complications in this area, particularly affecting the bone, the eye, or the brain. Now, if we go to NICE guidance, which is given to doctors in the UK, particularly general practitioners, we can see that if a patient fulfills these criteria, then the recommendation at the moment is to use phenoxymethylpenicillin, co-amoxiclav, with clarithromycin being reserved for patients who have a known allergy to penicillin. The thing that's somewhat counterintuitive in this recommendation is that if that doesn't work, then you've given co-amoxiclav and now you give some more amoxiclav to try and make it better. So I think there are some problems with these recommendations, but you can see where they're coming from. What is interesting, though, is that the NICE guidance does acknowledge that clarithromycin is active against most of the bacterial pathogens involved in this condition, and that it is better tolerated than erythromycin, with a more convenient dosing regime, twice daily, which obviously can lead to higher compliance. So if we look at some of the studies that have been done comparing clarithromycin with amoxiclavulanate, we can see that for clinical success in acute maxillary sinusitis, there is comparable, if not slightly improved, clinical success for amoxiclav and for bacterial eradication. And when we come to speed of recovery, both for nasal congestion and for purulent discharge, the clarithromycin is actually working statistically better than its comparator here of amoxiclavulanate. Now, what's intriguing is that despite that NICE guidance and quite close supervision of our GPs, we have recently done a study looking at the prescribing habits of GPs in the treatment of acute exacerbations of chronic rhinosinusitis for the first prescription. In other words, for the first drug of choice. And what we've seen, something quite intriguing, is that between 2000 and 2015, there has been a gradual increase in the utilization of macrolides as compared to penicillins. So that message from NICE is not necessarily being followed by our general practitioners. So we can say in summary that when we come to clarithromycin in the treatment of acute bacterial rhinosinusitis, it's a good alternative to penicillins, whether the patient is allergic or not, and we know that it's effective against the pathogens of a rhinosinusitis and is well tolerated. So what about chronic rhinosinusitis, something which is very close to my heart? And I have to say straight away that what I'm going to say now is not, as yet, a labelled indication for macrolides, though I'm confident that it will become so in the not-too-distant future. There was, many years ago, and still is, a very intriguing condition in Japan, which was called diffuse panbronchiolitis. And this condition was a non-eosinophilic lower airway disease, which was extremely dangerous and led to the deaths of many patients. And somebody hit upon the idea of using a long-term low-dose course of erythromycin, by which I mean given over a year or longer. And remarkably, it transformed the survival of these patients, so that 10-year survival went up from 12% to 90%, with improvement in both their clinical and radiological features. But what was very intriguing was that if you looked at the serum or the sputum levels of the drugs, they were much lower than the minimum inhibitory concentration, suggesting that these drugs were having an immunomodulatory effect rather than an antibacterial effect. And since then, as some of you will be well aware, these drugs, macrolides, have been used in long-term low doses in the treatment of a number of lower respiratory tract problems, things like cystic fibrosis, bronchiectasis, and COPD, which generically we might refer to as non-eosinophilic diseases. And indeed, there have been positive randomized controlled trials in favor of macrolides in cystic fibrosis, COPD, and asthma, where it is relatively low in eosinophils. Now, many of these patients who had panbronchiolitis also had sinusitis, and they had observed that when the patients were taking the drugs for their chest, their noses got better. And so Kikuchi and colleagues in 1991 published an open study in which they showed that the long-term effects of erythromycin were very beneficial in chronic rhinosinusitis. Now, it's quite intriguing that you should have drugs, and it's not just macrolides. Macrolides exhibit it very, very strongly, this anti-inflammatory and immunomodulatory capacity, and it does it in a number of ways. There is a change in the pro-inflammatory cytokines such as IL-8 and TNF-alpha. There is a reduction in the number of neutrophils, an increase in the destruction of neutrophils by degranulation and apoptosis, and a decrease in cell adhesion. They also suppress nitric oxide production from macrophages, and as we've heard, the importance of biofilms, they will disrupt biofilm formation, probably by affecting quorum sensing. And they will alter the mucus formation and its actual amount and viscosity, which translates into an improvement in mucociliary clearance. Now, all of those features we know are important in the pathophysiology of CRS. And this is a very common disease. We've heard some figures from India. In the Galen study, which we conducted in a number of European countries, we showed that the prevalence was just under 11% in the population. And of that 11%, 2% had nasal polyps and 9% had CRS without nasal polyps. So this is a very common disease. Now, we have argued endlessly about how we demonstrate the sort of relationship between CRS with and without nasal polyps, and it's a pragmatic decision to make this division, because one can see it with an endoscope and because studies have been done based on it. We know it's not as simple as that by any means, but we could say, if we wanted to be pragmatic, that you can divide patients up into those that have a predominantly eosinophilic disease, i.e. the patients with polyps, and those who have a relatively low eosinophil count in their disease process. Now, if we use that as our division, bearing in mind that it is, of course, a spectrum, we can say the Th2 diseases include things like asthma, things like nasal polyps, and we know that they are generally steroid responsive. Well, are they? The answer is yes, because we have a number of studies which show both with and without nasal polyps that the studies favour intranasal corticosteroids over and above a placebo arm. And certainly in patients with polyps, nearly 2/3 of the patients respond compared to 37% to placebo. But when we look at patients without nasal polyps, the response is much less. It's less than 50% as compared to 30% with placebo. So that's not really a very good result. When we looked at our patients in the Galen study and did a cluster analysis, we were able to divide the patients up into sort of vaguely Th1 and Th2, by which we defined them as IL-5 negative or positive. And we looked at the various cytokines that were associated with these diseases. And what it was possible to do was to find a huge number of endotypes. We had 18 or 19 endotypes. So we know that even within these obvious groups, these phenotypes, we actually have a very heterogeneous problem to deal with. And that's why patients don't always do well with the drugs that we give them. So when we look at the Th1 response down here, our patients without nasal polyps, this is where the macrolides are useful. And this is where we really need help. Again, this is a busy slide, it won't project well, but this is really just to show you that in Japan, a large number of what we might call level 3 studies were done. They were open studies, there was no placebo arm, but they included drugs like clarithromycin, roxithromycin, given over an extended period of time, 3 or 4 months, and showing benefit in the various outcomes that were looked at. So a few years ago, we did a study where we randomized patients either to a macrolide, in this case 250 milligrams twice daily of clarithromycin for 2 weeks, followed by 250 milligrams a day for 10 weeks, or to surgery if they had failed a 6-week run-in with topical steroids and douching, and they had to fulfill various other arms. And then we assessed the patients throughout a period of time. It was part of a thesis, up to a 1-year final assessment. And we used a whole raft of different outcome measures in visual analog scores, quality of life measurements, and other objective parameters of nasosinus function. And we had 90 patients in the study. And of course, half of those patients were asthmatic, and we used a number of outcome measures in the asthmatics, use of medication, hospitalizations, and objective measures such as FEV1 to assess the effect of the treatment. Now, what was really interesting, and I didn't prejudge what the results would be, but I was interested to see that actually there was significant improvement in all the subjective and objective parameters, in